Have our next speaker, and Professor Kiho Park from Korea is going to talk about something very interesting, which is myopia and glaucoma. He has a very large follow-up of myopic patients, and this is something which is really a dilemma for a lot of us in India also. Thank you.
It's my great honor to be invited. These are my financial disclosures. So globally, the prevalence of myopia is increasing dramatically. About in 2050, about 50% of the world population will be myopic, and 10% of the population will be highly myopic. And especially in East Asia and Southeast Asia, the prevalence increases more dramatical. So glaucoma diagnosis and monitoring in myopia is challenging because it is difficult to distinguish glaucomatous changes versus myopic changes. And in myopic eye, this could tilt with temporal stretching, peripapillary atrophy, and chorioretinal atrophy make it difficult to diagnose glaucoma. And in myopic eye, there is glaucoma-like visual field defect. So where are we looking for the structural diagnosis of glaucoma? We are looking at the optic nerve and peripapillary area, and also we look at the retinal nerve fiber layer with photography or with OCT. And also we are looking at the macular region to look at the ganglion cell layer change. And also we can take wider image of OCT, including both peripapillary and macular area together. To diagnose glaucoma, this hemorrhage is a kind of very nice clue. If we compare POH eyes in myopic disc hemorrhage and non-myopic disc hemorrhage, there is a significant difference. In myopic disc hemorrhage, it is most frequent in the lamina cribrosa area. In contrast, in non-myopic disc hemorrhage, they are least frequent in lamina cribrosa area. In this case, recurrent disc hemorrhage in lamina cribrosa area, B and C, you can find it. And after absorption of the disc hemorrhage, you can find lamina cribrosa change in that region. And also, visual field progressed in that region. Retinal nerve fiber layer photography can help us to diagnose glaucoma. So in this case, you can find superior temporal and inferior temporal defect, so we can diagnose glaucoma. And after 4 years, you can find progression, widening of the defect width. So we can also detect progression with RNFL photography. However, in myopic eyes, this kind of clear RNFL defects are not frequent. So this is case number 1, 28-year-old lady, quite young, with IOP21 and highly myopic. So quite strange optic nerve head and peripapillary change. And you can see some suspicious RNFL defect in inferior temporally. And OCT can clearly see those defects, and it can clearly tell us. And also at the macular area, you can see the superior and inferior difference, asymmetric ganglion cell layer change. Visual field is like this. So it is quite young lady. So some may think it does not change. It is due to the elongation of myopic change during the adolescent period. However, if we follow this patient for 10 years, it is progressed. So this is a myopic glaucoma case. It's not myopic optic neuropathy. And Japan group has shown that in highly myopic eyes, papillary macular bundle defect is quite frequent. This may be related with the tractional stress on the optic nerve head and lamina cribrosa in the temporal part of the disc. And also, if we are using glaucoma hemifield test to diagnose glaucoma, similarly, we can use a GC-IPL hemifield test, and we can compare the superior and inferior ganglions in a plexiform layer, GC-IPL layer, And we call that the temporal rapid sign positive. And also, we need to differentiate the red disease pseudo abnormal RNFL defect because of the shifting of the superior and inferior bundle thickness into the temporal side. So it is common in both in Asian and European eyes. So this is a healthy myope case, minus 6.5 diopter. And you can see the thickness curve, superior and temporal thickness curve shifted temporally, and it touches 5% normative database and 1% of normative database, and it creates red disease like this. It is normal myopic, healthy eyes. So we need to look at the thickness curve in myopic eyes, whether the curve is shifted to temporal or not. So case 2 is a 40-year-old lady, myopic, and RNFL defect was shown in the deviation map. We need to look at the thickness curve. So superior part, it is due to the shifting of the superior solid line to the temporal side. So it is red disease. However, inferior temporal RNFL defect, which is also shown in the RNFL photography, it is real defect, and it can be confirmed by the GCIPL deviation map. We call that temporal rapid sign. So back to this slide. The strength of the temporal rapid sign is it is free from false positives associated with normative database, poor normative database, which not include the highly myopic eyes. Another study was to compare the temporal rapid sign in highly myopic eyes, including glaucoma and non-glaucoma cases, and AURC GCIPL hemifield test was 0.938. It is better than average RNFL thickness and average GCIPL thickness. Another part is we can measure the neuroretinal rim with OCT. So BMO MRW measures from the BMO to the internal limiting membrane in spectralis OCT. Same concept is in serous OCT, called that 3D neuroretinal rim thickness. So in healthy myopia and myopic glaucoma, we compared RNFL thickness and this 3D neuroretinal rim thickness. So the left graph is RNFL thickness. It cannot differentiate glaucoma with red disease. However, 3D neuroretinal rim thickness can clearly differentiate red disease from glaucoma cases. Another one is we need to remove the confounding factor like systemic factors in our body. So if we compare both eyes with asymmetric axial lengths, we can only look at the factor axial lengths, and we can compare longer eye and shorter eye in one individual, and whether the eye is severe in glaucoma and whether the eye is faster in progression. So about 4.2% were the eyes with axial difference more than 1 millimeters, and among them 95 eyes, 95 individuals were included in this study, and their baseline intraocular pressure were not different between longer eye and shorter eye. And also, longer eye showed a larger beta and gamma zone peripapillary atrophy, and longer eye showed higher ovality index. And interesting finding was RNFL change per micron per year and GCIPL change micron per year was faster in longer eyes compared to the shorter eye. So this is the case with longer eye showed significant progression in RNFL GPA analysis, and also in RNFL analysis and GCIPL analysis, GPA analysis. So the conclusion, when the axial length difference is more than 1 millimeter, glaucoma tend to be more severe and to progress faster in the longer eyes. The last one is we investigated whether the intraocular pressure reduction is related with the slowdown, the progression of highly myopic glaucoma. It's a 12-year follow-up study. And also we want to identify which risk factors are predictive of progression of glaucoma. The result is disc hemorrhage was the significant risk factor for the glaucoma progression in highly myopic eyes. And percent reduction of IOP showed borderline significance. So we divided the upper tertile group and lower tertile group. Upper tertile is percent IOP reduction from baseline is more than 23.3%. Lower tertile was IOP reduction less than 11.1%. So upper tertile, large amount of IOP reduction group showed significantly greater cumulative probability of non-progression compared to the lower tertile group. So in summary, for diagnosis and monitoring of glaucoma in myopic eyes, disc hemorrhage and RNFL evaluation are important. It is crucial to differentiate rare disease from true defect by reviewing RNFL thickness curve. The combination of peripapillary RNFL analysis and macular GCIPL analysis may enhance diagnostic ability. Minimum rim width can complement RNFL thickness measurement in differentiating myopic glaucoma from myopia. Glaucoma tended to be more severe and to progress faster in the longer eyes. IOP lowering treatment may slow down the myopic glaucoma progression. Thank you for your attention.
Thank you, Professor Key. Any questions from the audience? I have a question. If there is a patient who's, I mean, how do you bring down the IOP in a myopic patient who's progressing? Is it on medical therapy, or have you had to do surgery also in some of these cases?
Yeah, in case of maximum medical therapy, if they progress, I do surgery. But in myopic eyes, trabeculectomy is quite problematic, but we do surgery
Also,
carefully.
yeah. Thank you.
Wonderful experience and talk. Two questions. One is, in highly myopic eyes, the corneal hysteresis also is different. So was that a confounder in measuring IOP? Although I understand the same eye was measured pre and post, but was that a confounder which was taken care of? And second question is, what is the response of SLT in myopic eyes as a treatment modality vis-a-vis non-myopic eyes?
Okay. Yeah, I think the corneal property is very, very important. Corneal biomechanical property may be related with the optic nerve head lamina cribrosa biomechanical property. Yeah. So in those myopic eyes, every myopic eyes are not glaucoma. Some of them are glaucoma. They have higher risk. Why? We don't know still exactly, but as you said, that kind of biomechanical property, susceptibility in highly myopic eyes and myopic eyes are associated with glaucoma development. So that may be related why East Asian eyes, Korea, Japan, and China, they have more susceptible optic nerve with very small elevation of IOP. So that may be related with.
Is that thinning of RNFL? I'm just thinking long term. We are seeing an epidemic of myopia. Is that thinning of the RNFL because of this biomechanics of the lamina cribrosa, let's say, extrapolating the corneal biomechanics? Is it going to cause a functional damage in the, not only the visual field, but in the functional, let's say, the ERG or the other aspects? Or is it just a thinning which is being reflected in the perimetry because that's geared up to think of thinning as damage? I'm just putting a question on that point.
Yeah, the thinning itself is, I think, they appears first in our experience, so and then we follow up them, their visual field changes.
Is it damage or is it thinning?
Yeah, their ganglion cell is lost.
Is lost.
So I think it's damage at the lamina cribrosa.
And the SLT part?
Oh, SLT. Yeah, we also do SLT if the pressure is high teen. But in case of low teen, SLT, it is not working quite good. So in high IOP,
But does it work
high teens.
differently vis-a-vis non-glaucomatous eyes? That was my question.
Sorry?
SLT, would it work better in a myopic eye or a non-myopic eye?
Oh, we did not compare. We need to do that
Okay,
in
thank you.
perspective.
Professor Koot, you have a question?
Keho, it's always wonderful to hear you talk on this. And obviously, glaucoma, we think of it as a trabecular meshwork disease in a sense to start with. But myopia has sort of three different types of disc. The sort of hypoplastic small disc, the sort of relatively normal, and then there's the macro disc. Do you get any sense of whether the risk is different for the disc anatomy, the underlying disc anatomy? Is it people with the small disc? Is it people with the macro disc? Is it related to how much peripapillary atrophy is there? Do you have a sense of that?
Yeah, very good point. Myopic eyes usually have larger discs because originally or because of axial elongation, it may stretch. The disc is the lamina cribrosa is thinner, and it may increase susceptibility to damage mechanically. So that's our speculation, but we need more information.
There are myopes though with small discs. With quite, well, we see them. I'm not
At
sure.
the beginning,
Yes, no, those quite hypoplastic and small discs.
I think hyperopic eyes are small.
I promise you, we have had them.
Really?
Yeah.
So it may be there may be racial
that's right, it
differences.
might be differences in the causation.
Asian eyes has large
Yeah.
disc,
Yeah.
and Western eyes have smaller disc. So maybe that affects.
I'm not
Yeah, I
so
have
sure.
a question. You showed that the glaucoma progresses faster in eyes which are myopia. Have you seen the other way around? That in myopic eyes which have glaucoma, the myopia also progresses if the IOP remains borderline controlled. Because we do see a lot of our GOAG patients who have myopia which progresses
Mhm.
if the IOP is in the borderline range,
Yeah.
even in the adults.
Right. If the myopia progresses, like in pathologic myopia, it may increase their
Due to
susceptibility.
effect of IOP.
Right.
Yeah.
Right.
Any other question? Yeah.
When the posterior staphyloма is away from the disc, the disc appears smaller. That is one speculation.
Yeah.
Why the disc appears smaller? Because the posterior staphyloma sometimes it's away from the disc, or when it is involving the disc, they appear larger. So
I guess the-
usually it is larger,
Yeah.
but when the staphylooma is away,
because, it's a
it's being
offset.
pushed. Yeah,
If at the beginning the disc is round,
yeah.
and if the axial elongation,
Then it is
the
pushed
BMO
towards.
changes,
Yeah,
and the lamina moves, and BMO they're offset. So the actual by photograph the disc looks small,
yeah,
but actually
yeah.
it's not small.
And I need a question to you, sir. How do you monitor actually? I think no investigation is reliable. Every OCT, HPF, everything has its own plus and minus. But how do you in general monitor them with one single investigation, or you have OCT-A also in your list of investigation for
Yeah,
pyramid
we monitor by all modalities: photograph, OCT, visual field.
at every visit?
Right,
Okay.
right.